is Diagnosis Glaucoma with your hosts, Dr. Mona Kaleem
and Dr. Harry Quigley.
Greetings, everyone, and thanks for joining us again. Today's topic comes by a special request from one of our listeners. We'll be talking about uveitic glaucoma. That's a big word there, uveitis. We're going to talk about what that is in just a minute and how it causes glaucoma. The guest for our episode today is Dr. Jennifer Thorne. Dr. Thorne, can you tell us a little bit about yourself?
Sure. Thank you for having me on this podcast. My name is Jennifer Thorne. I run the uveitis division at the Wilmer Eye Institute, and I have been treating patients with uveitis and the complication uveitic glaucoma for about 20 years. My practice is in downtown Baltimore, and I have about 5 other colleagues that work with us in our division.
And Dr. Thorne, how did you get interested in uveitis?
I became interested in uveitis during my residency program. I liked the fact that uveitis involved all of the compartments of the eye, and that it kind of was a challenging puzzle sometimes to figure out what the diagnosis is. Often patients with uveitis might have an infection or a systemic disease, and so there is sort of a broader systemic implication with uveitis. It can also be a leading cause of blindness in patients, and so it's very rewarding to be able to treat these patients and help preserve their vision.
When you say that uveitis involves every part of the eye, can you actually go into some more details and just tell us in simple terms what is uveitis and what is uveitic glaucoma?
Sure. Uveitis is simply inflammation inside the eye. And that inflammation may be primarily located in the front of the eye, which would be anterior uveitis, or in the middle of the eye, just behind the lens, which is called intermediate uveitis, or it may involve the retina or the choroid, therefore it's called posterior uveitis. If all of those compartments are involved equally, then it is called panuveitis. Uveitic glaucoma simply is glaucoma in the setting of a patient with uveitis. Sometimes patients will have true glaucoma, other times they will have just elevations of eye pressure. But treating uveitic glaucoma can be somewhat challenging because the treatment for uveitis, which is corticosteroid, often raises intraocular pressure and sometimes can be part of the problem when it comes to managing glaucoma or high eye pressure.
So then is it the treatment for uveitis or the actual uveitis that can cause the glaucoma?
It can be both. And in fact, there are some types of uveitis that will present with a high eye pressure, and the use of steroid will lower the eye pressure, which is somewhat paradoxical compared to what you might see in other cases where to control the uveitis with steroid causes the eye pressure to go high.
With uveitis, you had mentioned infections. What types of infections or inflammatory conditions most commonly cause uveitis?
In our country, I would say 85 to 90% of uveitis is non-infectious. Of the infections that we typically look for, syphilis would be probably the most common. There are viral infections such as herpetic disease, herpes simplex, varicella zoster, and CMV. CMV can cause an anterior uveitis, or it can cause a retinitis or a posterior uveitis. The herpetic diseases of herpes simplex and varicella zoster can also cause anterior uveitis or posterior uveitis, sometimes known as acute retinal necrosis. We also see Lyme disease causing uveitis, and we also see tuberculosis causing uveitis. In terms of systemic medical conditions that are associated with uveitis, many of them are rheumatic diseases, such as ankylosing spondylitis or inflammatory bowel disease or psoriatic arthritis that might be associated with a gene called HLA-B27. Or there are others such as sarcoidosis, which is fairly common in the Baltimore area, or vasculitides such as Behçet's disease that can cause uveitis.
If someone's been diagnosed with one of these infections or inflammatory conditions, do you think that they should come to the eye clinic and get screened for uveitis?
Well, we screen some diseases, but not all. So, for example, people that have arthritis that are associated with HLA-B27, their uveitis tends to be very acute onset with a red, painful, and light-sensitive eye. And so screening isn't necessary in those patients because their symptoms will likely send them to the eye clinic. On the other hand, in young children with juvenile idiopathic arthritis, that anterior uveitis tends to be bilateral and tends to be in a white eye with very few symptoms occurring in pre-verbal children. And so therefore, screening for uveitis is extremely important.
Can babies also get uveitis?
Yes, they can. It is unusual. Well, to be fair, uveitis is unusual, period. But it is less common in children in general. And then it is unusual before the age of 1.
Okay, so just to kind of summarize, uveitis can occur in a person of any age, and it sounds like even if someone's been diagnosed with an inflammatory or an infection condition such as that, they don't necessarily have to come to the eye clinic, but people who come in with uveitis do get screened for the things you just mentioned.
Correct.
What are some of the signs and symptoms of uveitis?
For anterior uveitis, the more typical signs and symptoms are blurred vision, redness, pain, and sensitivity to light. For uveitis that is behind the lens, such as intermediate posterior panuveitis, the symptoms may be more subtle. They may be blurred vision, they may be floaters, they may be occasional flickering lights. There are anterior uveitis syndromes that also have very few symptoms. I give you the example of children with juvenile idiopathic arthritis associated uveitis. They have very few symptoms. So, as you can see, the symptoms can be variable.
And how do you diagnose this?
Well, you can see the inflammation when looking in the eye. And so you're looking at the anterior chamber using the slit lamp. You're looking at the anterior vitreous with the slit lamp, or posterior vitreous using a slit lamp and a lens. And you look at the retina with the 20 diopter lens, for example. So when people develop uveitis, we do dilate them to check all the parts of the eye. And then we may use some ancillary testing such as OCT testing or fluorescein angiogram to look for swelling in the retina or leakage in the blood vessels, just as examples.
Sorry, this is like a very interesting topic, and I don't think many of our listeners know much about it, so I'm asking a lot of questions about uveitis. In terms of the treatments, the corticosteroids, how is that administered? Is it medication drop? Do people have to take pills or get injections? And then what other treatments are there besides steroids?
Sure. Well, the short answer about steroids in terms of the method in which you use them is sort of all of the above. However, different types of steroids are effective for different varieties of uveitis. So for example, when you have an anterior uveitis where the inflammation is in the front portion of the eye, using a steroid drop is usually adequate to treat and control the disease. And then you taper the steroid, hopefully, to completely off, or to the lowest possible dose that allows you to control the inflammation. For intermediate posterior and panuveitis, you usually need something stronger than just drops because drops don't tend to penetrate beyond the lens. So now you're talking about regional corticosteroids such as injections or steroid pills like prednisone, or in patients that aren't able to tolerate steroids for a variety of reasons, or steroids aren't strong enough to control the disease, or steroids are required but the dose long-term is too high to be tolerated by the patient, then we use immunosuppressive drugs. And those are drugs like methotrexate or mycophenolate or adalimumab, perhaps some of the people have heard of some of these or they see them on TV. They can be used to treat a variety of other diseases like rheumatic disease. And so occasionally you might even see some of them on TV for drug commercials.
Sounds like a lot of these treatments involve not just the eye doctor, but also, for example, a rheumatologist and maybe a primary care doctor.
They can. I think it can be helpful. My group does a lot of the prescribing of the systemic medications ourselves, and we do a fair amount of our monitoring. But it's always helpful to be in touch with the primary care doctor when a patient is, for example, on prednisone, because you're wanting to make sure that their blood pressure doesn't increase or that they don't have trouble with their blood sugar or develop diabetes. So having people to assist in the monitoring can be really helpful. Some uveitis specialists actually use rheumatologists to prescribe immunosuppressive drug therapy for them. And we do work with rheumatologists on occasion, but the majority of our patients that we see at Wilmer, we tend to take care of the immunosuppressive drugs and the monitoring of those drugs ourselves.
And I know that you had mentioned that the corticosteroids can, they treat the inflammation, so it's a good thing, but at the same time, there is the potential for them to increase eye pressure. Do the other therapies for uveitis, like ones you had just mentioned, do they also cause glaucoma or high eye pressure?
No, they do not. And systemic steroid doesn't tend to raise eye pressure as much as the more local therapies. So if you think about a corticosteroid that is delivered locally, such as a drop or an injection, the risks of developing, say, cataracts or high eye pressures is greater, but the systemic risks to the body from that type of corticosteroid is quite low because there is minimal systemic penetration of the drug. Systemic steroids is the exact opposite. Most of the side effects are systemic in nature, and the risks of developing cataract and glaucoma are lower. They're not zero, but they're lower, and they tend to occur more slowly than with regional or topical corticosteroid. The immunosuppressive drugs don't cause eye pressure issues or cataract issues.
And if someone has uveitis, would they have any signs or symptoms of glaucoma in particular, or are they the same as those for just general uveitis?
You mean if a patient has uveitic glaucoma, would they have symptoms like uveitis?
Well, are there any symptoms that are different for those who have uveitic glaucoma?
No, I think the symptoms of uveitic glaucoma would be more similar to the symptoms of glaucoma in general. So uveitic glaucoma can present in a variety of ways. You can have what appears to be, kind of an open angle glaucoma where it is clinically silent, and it may be partly due to scarring or damage to the trabecular meshwork from the actual inflammation, or it could be due to the corticosteroid effect, but it behaves like an open angle glaucoma. There are other types of glaucoma that are closed angle glaucoma that can come from uveitis. Probably the one that most of us worry about the most is if you were to develop a pupillary membrane or scarring of the iris down onto the anterior capsule of the lens, causing fluid buildup behind the iris and close off the angle. And those patients would be quite symptomatic, but their symptoms would mirror acute angle closure glaucoma and not necessarily uveitis.
For our listeners, remember in previous discussions we've talked about open versus closed angle glaucoma and the causes. So what Dr. Thorne is talking about is how uveitis or inflammation of the eye can cause glaucoma in either situation. So in someone with an open angle, their eye pressure can go up when there's potential for scarring of the trabecular meshwork, or the outflow through the trabecular meshwork is just not as adequate as it needs to be. And then she mentioned with angle closure, so if the scar tissue actually closes the trabecular meshwork over to the point where, the scar tissue is so extensive that the meshwork is no longer open, then that can cause an angle closure. glaucoma, but again, from uveitis. So you can get either situations. And I know that the treatment for uveitis is with steroids or with immunosuppressive therapy. But Dr. Thorne is going to talk to us about the treatment specifically for uveitic glaucoma in the two major ways, the angle closure or the open angle type. And she'll also talk to us about a third type of treatment, which is when it's induced by the treatment. So that then brings us to our next topic, which is the treatment for uveitic glaucoma. So Dr. Thorne, can you tell us how you start with the treatments?
Sure. So one of the things that I think sometimes is confusing to people is that if you've got a patient that is on topical corticosteroids and their uveitis is controlled, but their eye pressure is high, that you might be able to just stop the steroid to fix the high eye pressure. And in fact, a lot of times stopping the steroid will in fact lower the eye pressure back into the normal range. But the problem is that in many patients with uveitic glaucoma, that will also cause the uveitis to return. And having an actively inflamed eye and trying to bring eye pressure under control, if surgery or laser or other non-medical reasons are required to control the eye pressure, is problematic because the inflammation often will cause more complications from any glaucoma procedure that you might try to undertake. So it becomes incredibly important to maintain control of the uveitis. So if you've got a patient that requires, say, 2 drops of steroid a day to control their uveitis, but their eye pressure is beginning to rise, what we recommend is to start medication to lower the eye pressure rather than adjusting the steroid. And there are people that struggle with that a little because people will say, well, why don't we just allow for a little bit of inflammation and the pressure will be better and they'll be on less steroid. But a lot of the uveitis outcomes suggest that even a trace amount of inflammation, particularly in children, can be associated with long-term complications of the uveitis and poorer visual outcomes. So we try to optimally manage the uveitis and then secondarily manage the pressure. Furthermore, if the patient ever gets to a point where they need glaucoma surgery, having that uveitis under control increases the likelihood that they're going to get a good result from their surgical glaucoma procedure.
And in terms of the treatments, in my experience as a glaucoma specialist, many of the treatments that we use for angle closure and open angle glaucoma do also work for uveitic glaucoma, but of course we have to be very careful with the inflammatory response that can occur. So a patient with uveitis could potentially have a laser trabeculoplasty procedure. That might be a controversial statement, but if they've been quiet, you can actually do the treatment in divided doses. And that's, of course, if their angle is open. If someone with uveitis has developed an angle closure because of all of the scarring, then we treat with a peripheral iridotomy, which is the same for any run-of-the-mill angle closure. Sometimes we need to do surgery, so putting one of the tube implants in or potentially a trabeculectomy. We can also potentially do one of the minimally invasive glaucoma operations, but again, we're always weighing the benefits and the risks, taking them into hand. Also, there is potentially a need to treat with some of the therapies that Dr. Thorne is talking about, like steroids or the immunosuppressives, before having one of these surgeries and in the postoperative period as well, to try to prevent a rise in the inflammation, because that can be very problematic for patients. In addition to the glaucoma causing blurred vision, a red eye, and discomfort, it can also happen just with having the inflammation, or having the high pressure. So we try to really control everything as much as possible going in. I do find, Dr. Thorne, that when patients are taking the immunosuppressives, it seems like there's less of a need for an urgent surgery in the immunosuppressive therapies. Do you agree with that, or have you seen that also?
First of all, I'll say I'm a little biased. I do believe that in general, clinical outcomes are better for patients when immunosuppression agents are used for quite a few of the chronic uveitis. So I tend to be a fan. If I've got a patient with anterior uveitis that's on a very small amount of steroid, I am a little hesitant to add immunosuppression for that reason and that reason alone, unless they're a child with JIA uveitis, in which case typically we will start immunosuppressive therapy earlier in those patients. But I think your observation is correct on the whole, that people that are on immunosuppressive drug therapy usually have pretty tight control of their uveitis, and therefore there is time to try to figure out when and what procedure would be best for the patient. And we can kind of work more with a broader variety of treatments from our glaucoma specialists when that uveitis is really well and tightly controlled. Whereas if a patient is more fragile in terms of their controlling uveitis, a lot of times you don't have the same luxury of time. I also think that those patients do better with a variety of the glaucoma surgery and often don't need as much steroid prophylaxis for the surgery if they've been on immunosuppression for a while.
I know that immunosuppressive therapies have their own, risks, but to me, it seems like it's better than being on steroids. I don't know if you agree with that.
It's interesting because I think the more I do uveitis, the more I say the very annoying phrase, "it depends," but it feels like "it depends" is kind of almost the mantra for uveitis. There are cases where a little bit of steroid will work very well, and often you can get people off of the steroid quite quickly. Occasionally, we will use steroid pills as prophylaxis for patients in the short term around surgeries with no intent for them to have to stay on them after the fact. And I think that there's a good group of patients out there that are controlled with 1 or 2 drops a day as adults, and they're in their 60s and they've had their cataract surgery. And in those cases, they're not getting any side effects systemically from anything. And as long as their eye pressure is behaving, I don't think I would favor changing them over to an immunosuppressive drug simply because I couldn't get them off 1 or 2 drops. I hope that makes sense. It's definitely a balancing game.
Yeah, I've also seen that. A lot of people ask me, okay, I have uveitic glaucoma. Am I going to be on these treatments forever? And just as you said, it really depends. And the treatment that may be for one person might not be the one for you. It can vary by patient, and it can depend on your age, your risk factors, if you have scarring, so many different things.
I completely agree with you. I wonder if you have noticed this in your practice, that there is a group of patients that do fine, and they do fine forever on a very few number of drops, be it a low dose of steroid or a low dose of glaucoma medication. But then there's this other group of patients that they will be fined for a period of years on a single IOP lowering medication, and then suddenly have high pressures and require, maximal medical IOP treatment, and often will go to surgery. And it's always a very interesting group of patients because their uveitis has been inactive and they haven't changed their steroid dose, but it's like all of a sudden the eye pressure spike becomes manifest and there's nothing you can do medically to reestablish the control. I don't know if you have seen that, but I've got a subset of patients that I feel like that happens.
Oh yeah, I've definitely seen that. And that really underscores the point. I want to get this point across to everyone. If you have uveitis or uveitic glaucoma, please don't be lost to follow-up. And please especially don't be lost to follow-up taking steroids. If you're on steroids, you must come for your eye exams. And if you have uveitis especially, please don't be lost in the system. Please make sure you come and get seen, because the damage that uveitis and the glaucoma causes can be irreversible.
How often do you ask your patients if they're on steroid to come in or have their pressure monitored? Are you every 3 months, every 4 months, every 6 months?
It really depends again. So, you and I work together on many patients, and I think it's important for a glaucoma specialist and a uveitis specialist to work together to co-manage patients. So what you and I typically do, what I've observed that without even talking to each other about it, what we normally do is that a patient is seen every 3 months by one of their doctors. So it could be the glaucoma specialist or the uveitis specialist, but it should be spaced so that they get an eye exam every 3 months, but approximately every 6 months by one of the two specialists. Is that what you do also? That's kind of what I've noticed that I do with the uveitic colleagues.
Yeah, that makes me feel safest when I've got somebody that has been doing well, and you get sort of the sense of the fatigue of coming for visits. But I've had just a few patients who were doing very, very well on drops that we had spread visits out to every 4 to 6 months, and then they came in with really high pressures. And so I feel like that's been kind of almost the compromise with some patients. Okay, well, you don't have to see me specifically every 3 months, but if you see me and then your glaucoma specialist 3 months from now and then me 6 months from now, and that seems to do fairly well.
Yeah, I agree with that. And the way that we monitor the glaucoma in patients who have uveitis or ocular hypertension due to uveitis, or the treatments for uveitis, are similar to the other glaucoma patients. We do visual field testing, we get optic nerve imaging, we check eye pressure, check pupils, that sort of thing. Always get an anterior segment exam and also a look at the back of the eye. Is there anything that you do differently, Dr. Thorne, to monitor the uveitic glaucoma patients besides what I've just mentioned?
No, not really. I mean, I think maybe there may be a few nuances, and that is particularly if patients are having, an occasional high eye pressure, or if they're showing some differences on testing. I like to, if I'm the only one following their glaucoma at that time, I'd like to get a glaucoma specialist involved, because it's nice to kind of get another set of eyes, an idea of a target pressure, particularly if it looks like there may be a need for something more than just drops. I would prefer to have that expertise involved sooner rather than later. And then what I coach my patients is that if I'm referring you to a glaucoma person, then that person is in charge of your glaucoma, and you're not, you can't, play the parents against one another. You have to do what they say for your glaucoma. And patients, I think, they're really good about, following the recommendation. If you kind of come forward and say, okay, well, this is the person that is going to be the quarterback for the glaucoma, I think they appreciate that it limits any confusion.
In between visits, patients can either purchase or rent a machine to check their eye pressure at home. Dr. Thorne, I know that you've done some work with that, with the home monitoring. Can you tell us a little bit about that?
Yeah, I mean, I am very excited about this as a possibility. I've not done a lot of the work yet, but we are going to start recruiting patients that have had steroid injections to do some home monitoring to see if we can get an idea of whether or not there are wild variations in eye pressure, or if there's differences between those that end up with higher pressures, say at 1 month, versus those that have normal pressures. I'm very much looking forward to doing this in some of our chronic anterior uveitis patients that already have ocular hypertension to see what they're doing. And there's a posterior uveitis group that I do a lot of research in called birdshot chorioretinitis that seem to have more sensitivity to pressure spikes in terms of changes in their optic nerve and need to having glaucoma surgery. It's been observed previously. I would love to see what they're doing. But I think it's a fabulous asset for our patients to try to understand, what the ebb and flow is of these eye pressures. Because, as you and I are both painfully aware, and we haven't really talked about the other end, which is pressure too low, which is also equally awful. And so, trying to understand where an eye pressure goes during the day and during the evening, I think it could be very, very helpful.
That's actually a great topic, which is hypotony, or pressure that's too low. We'll probably have to spend another episode on that. I'm glad you mentioned that.
Yeah, no, I think that would be a great idea. I think hypotony is one of those things that almost goes hand in hand with uveitis, whether or not the person has a history of glaucoma or not. So I think it definitely would be a great podcast.
And for the listeners, the reason why someone with uveitis may get pressure that's too low is because, and Dr. Thorne, please chime in and tell me if I'm saying this correctly, if you agree with me, but it's because the gland that produces the fluid in the eye, it gets very tired. It's part of the uvea, so it's part of that tissue that is inflamed. It can get tired and then just stop functioning as well, what we call hyposecretion.
I mean, you can have it be temporarily shut down in acute inflammation. It can be temporarily shut down after surgical procedures, or it can be more chronically shut down when the damage to the ciliary body has become so extensive that it just doesn't want to produce fluid.
Yeah, very big topic to discuss. I'll bring that up with Harry since he's really an expert in hypotony. I do want to put in a plug for anyone who's interested in renting or purchasing one of these, what we call eye care home tonometer machines. If you're anywhere near Johns Hopkins, you can rent one through us. We do the training for you or your family member. And also there's a great service. It's myeyes.net. It's a website. It's a company. It's their website, but you can actually purchase or rent an eye care home tonometer through them. So I have a lot of patients who get their eye care through myeyes.net or, through us at Hopkins, but either one I think are good. For those of you who are looking for a tax break for having an eye care, so if you get one of these, then ask your doctor if they can write a prescription for you or a letter to take advantage of the tax benefit there. Dr. Thorne, can you tell us more about the work that you're doing in uveitis? This topic has been really fascinating, but we're just very interested in knowing about your interests, your research, any recommendations you have for our listeners.
Well, sure. Thank you again. I do a lot of what I would call treatment outcome, visual outcome types of research. Some of the diseases that I look at more closely include birdshot chorioretinitis, JIA uveitis, both of which I brought up today, HLA-B27 uveitis. So I use kind of some of the stuff that I'm studying as the examples today. And we're looking at things like side effects of medications, which medications work well in these patients, what types of ocular complications these patients get, and of course, high eye pressure, otherwise known as ocular hypertension, or uveitic glaucoma are right at the top of that list, along with a disease that affects the retina called cystoid macular edema. Those are probably the two complications that I look at the most closely. As I mentioned, we're participating in a study with Dr. Johnson. I think, Mona, you're involved as well, looking at steroid response using those home monitors. And so I'm looking forward to seeing what direction that takes us, because I think that uveitic glaucoma in and of itself has been understudied in the past. And so I'm hoping that our group will be working to, remedy that a little bit in the future.
Yeah, it's very interesting work. I'm excited to see what our results show us. For anyone who's listening who wants to participate in the study, you can certainly reach out to us. You can contact us through the Diagnosis Glaucoma Gmail account. It's diagnosisglaucoma@gmail.com. You'll also see on our website, diagnosisglaucoma.com, you can find a page to write us questions or reach out to us with comments, or you can certainly comment on our social media accounts. For those who want to support Dr. Jennifer Thorne's work, you can reach out to her development officer, who is Miss Daniela Freed at Johns Hopkins. Daniela's phone number is 443-287-0573, and her email address is also on the Diagnosis Glaucoma website. Thank you so much again, Dr. Thorne. And do you have any last few things that you wanted to share with the listeners?
No, other than to say thank you again for inviting me to be on this. So I'm excited that there's so much available information for our patients with glaucoma. I think this is fantastic.
Thank you. Thank you very much. This is a very interesting topic. I know it's been one of the lengthier topics, but it's just so interesting. Thank you for joining us. I know you're very busy, and we really appreciate you making the time. And hope you'll join us again for another episode. Thanks, everyone, and we will be with you again for another episode soon. Take care.
Thank you for joining us. Until next time, your mom says take your drops.